Okay, I will start. It is 8. I'm Ruthie Landau. I'm delighted to have you in this room for a refresher course on anesthesia for cesarean delivery. Can I just tell you, I'm not the one who chose the topic. I was assigned the topic. It is so broad that it is overwhelming, but I hope to make it relevant in elements that I've chosen. So there's some bias in there that I've chosen things that I think are the most relevant to our practice. I don't have any disclosures or conflict of interest related to this presentation. The one thing I will disclose is that I'm the editor-in-chief of the International Journal of Obstetric Anesthesia. I am a SOAP past president from 2020 to 2021 during the COVID pandemic, and I'm currently the chair of the SOAP Centers of Excellence subcommittee. I guess I'm supposed to use this thing to advance the slide. Nope. I don't know how to do it. It's not. It was working yesterday when we were in this room, but there, I got it. Okay. The objectives of this presentation. We're going to review the epidemiology of cesarean delivery and associated maternal morbidity and mortality. We're going to describe anesthetic modalities for cesarean delivery and issues related to general anesthesia. We're going to identify select strategies ensuring optimal cesarean delivery with neuraxial anesthesia. We're going to talk about enhanced recovery and opioid-sparing analgesia after cesarean delivery, and we'll summarize current and future priorities focused on maternal health. It's going to be about maternal mortality, GA, neuraxial, ERAC, and the future. So the epidemiology of cesarean delivery and associated maternal morbidity and mortality. You may know, you may not know, that during this 1-hour session, there will be 30 women dying during childbirth around the world. So the WHO reported it's 1 maternal death every 2 minutes. So 92% of these deaths occur in low and middle income country, but some of them also occur in the United States. I did a show of hands before. I'll do it one last time. Who does not practice in the United States? Please raise your hand. 3 of you. Okay. So for those of us who do practice in the United States, we are the only high-income country with a rising maternal mortality rate. It has risen tremendously during the pandemic. It has gone down a little bit, but not enough. So causes of maternal deaths in the United States, number one is not the one you think. It is maternal mental health issues. And people often ask, what is that? So that's domestic violence, so suicide, postpartum depression and suicide. So 23% of people who die during childbirth in the US, it's from mental health conditions. Then comes postpartum hemorrhage and cardiac issues and thromboembolism. So the timeline of maternal deaths is usually postpartum, and so you may think as an anesthesiologist, we don't carry a role in making a difference, but we actually do, because the mental health issues that I mentioned are often related to having a traumatic childbirth experience, having postpartum depression, leading to potentially a substance use disorder, potentially overdoses, or potentially just suicide. So we do have a role, and yes, some of these occur at the time of delivery, where obviously we are there in the labor room, in the operating room, and it is our role to prevent these deaths. So it is interesting. Unfortunately, I'm going to repeat things you've heard a lot in the past years, and probably here as well, is that Black women are 3 times more likely to die during childbirth. And if you look at this interesting graph on the right-hand side, for Black women, it is not mental health. It is postpartum hemorrhage, hypertension, and the other causes of maternal death that we're more used to hearing about. So what is the projected number of cesarean deliveries in 2030? Even though there are many initiatives to reduce the cesarean delivery rate, it will still be, and it is projected to be 28.5% worldwide, which means 38 million women annually will be delivering with a cesarean delivery. That means 104,000 women daily. So for all those who went to other sessions in this meeting, they should have come to this one. Cesarean deliveries is the most common inpatient procedure. Thanks for being here. Now, for those of us who work in the United States, you have the graph on the bottom left side. The rate is going up despite all the initiatives to reduce cesarean delivery rates. So I wanted to talk about the Robson 10 classification. It is not well utilized in the United States. It is used quite a bit in low and middle income countries trying to report on cesarean delivery rates. And the reason I wanted to talk about the Robson 10 classification, it's just to remind everyone, we talk about cesarean deliveries as if it's the same procedure. Well, it is usually the same surgical procedure, but what brings a woman into the operating room for a cesarean delivery is a very different clinical circumstance. So this is not new. It was described by an obstetrician, Michael Robson, from Europe, and it was described in 2001 as a framework for assessing differences in cesarean delivery rates. It's based on 5 obstetric characteristics that are identifiable before the cesarean delivery. One is parity. The second is onset of labor. Was there labor or not before the cesarean delivery? The gestational age, is it preterm or not? The fetal presentation, breech or not? And the number of fetuses, is it singleton, twin, triplet, or higher order pregnancy? And so that brings patients into being categorized into one of 10 classes. And I know it's a little bit small, but all of them actually represent a combination of all these characteristics. So in a very recent study from a U.S. cohort, which hasn't happened very often that U.S. cohorts have been evaluated under the Robson 10 classification, you can see here that the most common group of women undergoing a cesarean delivery is the group 5 that represents multiparous women with at least one previous uterine scar with cephalic pregnancy and more than 37 weeks gestation. So these are the repeat C-sections usually. And so why is it important? It is important because as anesthesiologists, we're going to have to think about what are the expectations of women coming into the operating room? What do they know about a cesarean delivery? Was it expected or not? Was it desired or not? Are they coming in with a previous traumatic experience of a cesarean delivery that didn't go well, either because they experienced pain or they experienced postpartum hemorrhage or they experienced simply not wanting a cesarean delivery and being rushed to the operating room and feeling like they were about to die, which is something that women tell us about. So very important to know that when we take care of a cesarean delivery, most of the time they've had one before. So let's talk about anesthetic issues, and we're going to talk initially about general anesthesia. So the SOAP Centers of Excellence, for those of you who are familiar, is a designation that SOAP put together almost 10 years ago, trying to define excellence in obstetric anesthesia care and trying to define benchmark and metrics to ensure safe and favorable outcomes for women. And so the general anesthesia rate, not just by SOAP, it happens to be that the UK also in their NICE guidelines, put a benchmark, put a number. Obviously the number shouldn't be just taken out of context. It's in a context where every case should be reviewed and every case should be the opportunity to identify, was the general anesthetic avoidable or was it not avoidable? There are many times where it's not avoidable, but if it was avoidable, there should be some thought as to what could have prevented that general anesthetic. So the framework is that there should ideally not be more than 5% of general anesthetic in a labor room that provides excellent close to excellent obstetric anesthesia care. How do you achieve that? By having dedicated staffing. So it's not just the number of people, but also the experience, the expertise, the knowledge. You're here. Having labor epidurals that, if they are placed, actually work for labor analgesia. Don't have an epidural in place that doesn't provide labor analgesia and then expect that epidural catheter to provide anesthesia when a patient goes to the operating room for an intrapartum cesarean delivery. And we're talking a lot about what should be the rate of adjuvant medication. Should we give a lot of medication and end up having what could have been a general anesthetic without having airway protection? Or is there a time point where if the anesthetic is the epidural anesthetic or the spinal anesthetic for that matter isn't working, just convert to general anesthesia? Obviously, these are situations, and we'll talk about it later in my slides. But it's really important to have what is called now active management of labor and labor analgesia. So these are the steps: having dedicated staffing, having people in the labor room who understand block quality, progress of labor, maternal and fetal well-being, maternal decision-making, and obstetric decision-making. If you work in a labor room where many patients have an epidural catheter, but patients are never followed up, there's no rounding on patients, you don't know what the fetal heart rate tracings look like, you're more likely to end up with a stat section where you were not aware, first of all, that the patient was on their way to the operating room, second, that the patient has an epidural that was placed at some point, but is providing one-sided analgesia or no analgesia, or has had so many top-ups that you have to think that this patient is not within the ED95 but might need different interventions, potentially replacement, potentially adjuvants. And you will need to work to optimize the block before you get yourself into a situation where you have an epidural that's not working or a spinal that's not working, and treat the cause of breakthrough pain. And these are all the steps that have been again and again described. It is not new, but steps that are important to allow a reduction of general anesthesia. So you'll tell me, why are we focused on reducing general anesthesia? So most people will say or will think it's because we are afraid of the airway. Maybe we were afraid of the airway. And a lot of people will say that obstetric anesthesiologists don't know how to intubate. But this is really not the issue. It's not just the airway. It's not just that pregnant women are more likely to aspirate, which, by the way, is extremely rare. It's not just that they have a more difficult airway. It's not just that they're more likely to desaturate fast. There are many other issues. I put them there, and actually, you'll see these are the 18 points, and I'll show them all, for which I believe that we need to try to avoid preventable general anesthetic. So intubation can be difficult. Aspiration might happen once in a blue moon. But the issues are really not these. The serious adverse events, they could be respiratory with obstruction. They could be cardiac. They could be cardiac arrest. They could be cerebrovascular injury from severe hypertensive response, particularly in preeclamptic patients, the same patients that you did not want to do an Araxan anesthetic because the platelets might be low. They're just equally at risk of having a stroke if you don't blunt the pressor response and if you're not cautious with your intubation and your extubation. So induction issues intraoperatively, again and again, studies show that patients are more likely to have intraoperative hemorrhage, postpartum hemorrhage. And at the emergence, patients can aspirate, that thing that you were so attentive with your Selleck maneuver to prevent. We are not very good at preventing it at extubation. Aspiration of gastric content can happen. And if you don't have a dedicated PACU room, or if you don't have a unit that can assess those patients that are sick or those who are with morbid obesity, there's a risk of respiratory depression that is increased after general anesthesia. Postoperatively, studies again and again show increased postoperative nausea and vomiting. More pain, because if you didn't provide Neuraxyl opioids, patients are more likely to have acute pain, potentially persistent pain and opiate use disorder, reduced immediate skin-to-skin bonding and breastfeeding, decreased satisfaction, persistent pain, postpartum depression. Several studies now show increased suicidality. It's difficult to say that it's the general anesthetic itself, but it's the fact that there was a circumstance that led towards the general anesthesia. Maybe it's the pain, maybe it's the emergency, maybe it's the hemorrhage, but just, be aware that these patients will need follow-up. Surgical site infection, thromboembolic disease, and for the fetus and neonatal outcomes, reduced respiratory depression, higher admissions to the NICU. We're still not sure about in utero exposure to anesthesia agents, probably not a real issue, but something to bear in mind, and breastfeeding issues. So it's not just the airway. If you can avoid the general anesthetic, avoid it. So we described in a large, big database that in New York State, there was 5.7% of cesarean section without a clinical indication for general anesthesia. They were performed under general anesthesia. They'll say 5%. It's not that many, but it is a lot when you think about the number of cesarean deliveries. And we saw that there was an association with anesthesia-related complications, surgical site infection, venous thromboembolism, but not death or cardiac arrest. Yes, we will not kill patients by inducing general anesthesia, but there are a lot of other things that can happen. This paper was accompanied by an editorial covering, the issue of difficult intubation, fatal aspiration, intraoperative awareness. And I do want to just review very briefly with you this excellent article that was published in Anesthesiology a couple of years ago that was undertaken by the MPOG group, Multi-Center Perioperative Outcomes Group, that reviewed over 14,000 cases of general anesthesia for cesarean delivery and reported a difficult intubation rate of 1 in 49. I don't know what this number evokes to you. Does it mean it's common? Does it mean it's not common? Sort of a number out there. But the important thing is that the definition of difficult intubation was actually pretty not strict. In other words, more than 3 attempts, rescue fiber optic intubation. I don't know how often you use your fiber optic intubation, rescue supraglottic airway, a surgical airway. This is like really, really difficult airway. So the 1 in 49 has to be placed into context, and then failed intubation, any attempted intubation without successful ET tube. There were not that many, but again, do we want to get there? We do not. They identified risk factors which are well known to us, and so limited mouth opening, malempathy 4, associated with a difficult intubation. Now, the aspiration rate. We always say we need to wait for patients to be NPO because there is this aspiration rate aspiration risk that is so important. I'm not here to tell you not to comply with NPO guidelines from ASA, but just to review, this is an excellent study published last year that reviewed from 2 large tertiary medical centers, the general anesthesia of over 20,000 patients, and then they saw that with no aspiration prophylaxis, because most of these cases were urgent, pre-oxygenation with tight-fitting mask, and cricoid pressure, the risk of aspiration was 1 in 11,000 cases, and with a spinal, it was 1 in 25,000 cases. Why did I want to show this slide? It's because I often hear people say the obstetricians want to go to the operating room with a cesarean delivery that is not scheduled, where the patient ate something 5 hours ago, and they want the obstetricians to wait another 2 to 3 hours to comply with the 6 to 8 hours of nil per mouth. The issue with that is that if your patient within 5 minutes the baby has a deceleration or something becomes urgent, now you put yourself in the situation where you have to do a general anesthetic and you double the risk of having an aspiration, even though, as you saw, it's very low. So how about we communicate with the obstetricians? What is the likelihood that we can't wait the additional 1 to 3 hours or 6 to 8 hours? Do you think we'll find ourselves in a situation where we can't wait longer? I would rather go to the operating room and do a spinal under that circumstance than wait for the stomach to empty and then suddenly it becomes urgent. Or if you're facile with doing gastric ultrasound, why don't you just do a gastric POCUS and see whether there's still some food in the stomach? So when general anesthesia is not avoidable, of course that does happen, the UK Difficult Airway Society published an excellent paper. I'm not going to go through the algorithm, but you have all the situations of what happens, and a rapid sequence or modified rapid sequence induction is what is recommended. So you have your suction, your IV, you optimize the position, you pre-oxygenate, cricoid pressure, deliver appropriate induction or muscular blocker doses, and consider face mask. I'm going to move on to neuraxial anesthesia. So neuraxial anesthesia, I put here the figure of the yoga person Of course, I'm not implying that we're going to do yoga session during neuroaxial anesthesia, but my point is we need to ensure patient safety and comfort and well-being. How do we do that? There are many steps, but I summarize them like this. We need to avoid hypotension. If you avoid hypotension, patients won't be nauseous, they won't be reflex tachycardia, and you do that with a judicious choice of vasopressors. We'll cover that. You need to promote comfort, physical and mental comfort. You need to warm up your patients. You have to ensure they're not unexposed. You want to prevent, if you can, shivering. A lot of patients who have intrapartum cesarean deliveries arrive to the operating room, they're already shivering. There are ways to treat the shivering. In studies, when you ask patients what was the most uncomfortable phenomenon, a lot of them tell you that it was shivering. And when we tell them that it's actually treatable, they say, I wish I knew. We see that in our patients that come for a repeat cesarean delivery, where we tell them we're going to give you something to prevent shivering or to manage the shivering you might already have. They say, I wish I knew that because last time it was terrible. We want to prevent and manage nausea and vomiting. We want them not to be anxious. We definitely want them not to be in pain. And a lot of women will say they want to be in control. So it's difficult to allow them to be in control, but we can definitely discuss with them what are the things that are important to them. If you have the time to do that before they come to the operating room, it's great. Or even on the operating room table, whilst the obstetricians are prepping and draping, the little sentences, little communication that actually help women really not feel like they've totally lost control over that delivery. Because remember, a lot of women did not intend to have a cesarean delivery, did not choose to be willed to the operating room and feel like everything is going loose. For us, it's another day at the shop. For them, it is everything they were hoping for, not going the way they were expecting. We obviously need to ensure appropriate fetal perfusion, and for the neonatal outcomes, that there's appropriate resuscitation. So for neuroaxial anesthesia, I want to say, and I'll emphasize, no pain and comfortable during and after cesarean delivery. I want to put there, as a balance of that urgent situation, stat situation, where the patient comes to the operating room and we all think that the only thing we can provide is a general anesthetic with a rapid sequence induction. There's also the rapid sequence spinal. Who's heard of the rapid sequence spinal? Okay, a few, but not all of you. So this was described a while ago. This is a publication from 2010 from the UK, which describes what to do in an extremely urgent situation. It could be a cord prolapse, could be uterine rupture. If you have good communication with your obstetrician and you're good at doing spinals, don't let the med student do that, but you can do that. These are the steps. If the patient arrives to the operating room without an IV, you are going to have to place the IV anyway to do a general anesthetic. Let the nurse do it, or let someone from your team do it. You don't need to be the one doing it. Whilst someone is placing the IV, if the IV is already there, you clean the back, you have to do that. You might decide not to put a drape. You might decide not to do a local anesthesia infiltration. I usually do it. It doesn't take that long, but you might decide you're skipping that step. You put the introducer, you take a spinal needle, not a 27 gauge, because you're going to have to inject slower. So 25 gauge, one attempt. Obviously, you're going to say, how do I know it's going to be one attempt? You don't, but you hope that's what's going to be. And you inject fast. I don't think we appreciate and we realize how speed of injection makes a huge difference on the spread. So if you inject fast through a 25 gauge needle with maybe a higher dose than you would usually use, 15 milligram, you have to have your vasopressor ready. If you have the time to draw your opioids with it, fentanyl, morphine, add them. If you don't, skip them. It's unfortunate, but if that's what it takes, you can skip them. Lie the patient down as fast as you can. And it is recommended you could put them in Trendelenburg just to get a T10 level. And as soon as you have a T10 level, you can tell the obstetrician to start the skin incision. It will take another minute or two to reach T4, T5, which is what we need for uterine manipulation. This is not my description. This is described in this paper, but I can tell you that I do that quite often. I do add the opioids. It doesn't take me that long to do. It works. You should try it. And if it didn't work, you can always do a general anesthetic. So let's talk about neuroaxial anesthesia. There is the spinal and there is the epidural. I put here my recipe, okay? So it has been shown again and again, and it's written in all the papers that the ED95 for hyperbaric bupivacaine with the opioids, not without, is between 11 and 13 milligrams. So for those of us who work in the US where the hyperbaric bupivacaine is 0.75%, we usually draw 1.6 ml. You can draw 1.8 ml if you think the patient might need a higher dose. I often draw 1.8 ml because I really do not want my patients to experience pain. That is something I have changed in my practice in the last 3 to 5 years, I would say. Always add a short-acting opioid. Many people don't want to add it or don't think it's helpful, don't think it's needed. It is needed for the visceral pain that so many women report. Now, it is annoying to draw the fentanyl and have so much to waste, particularly in the US. It's a big deal. You draw an amp, it's usually more than 15 micrograms. You're going to have to discard the rest, but you have to add it. So many women now dread pain during cesarean delivery. We'll get to it on my next slides. So this is the cocktail. And then you want to add a long-acting opioid for postoperative pain and to reduce the likelihood of needing systemic opioids. So the dose doesn't matter. Some papers show that you need to reduce the dose. Some papers tell you that 250 is the dose. Anything between 50 to 250, everyone responds to it differently. Back in the days, my interest was pharmacogenetics of opioids. I can tell you that we all respond differently to that dose. So use 50, 100, 150, 200. It doesn't really matter. Not less, not more. Now, alpha-2 agonists, those of you who have some interest in the field know that it has become very popular over the years, despite the black box warning of the FDA against epidural use of clonidine. And the black box warning is just because it causes hypotension. But remember, hyperbaric bupivacaine causes hypotension as well, and you're going to prevent the hypotension with your vasopressor. So don't be shy if you think your patient needs a little extra. So how are you going to know that the patient needs a little extra? One very easy thing to do is to ask them, particularly if it's a repeat C-section, how did it go last time? You have an opportunity to know how the patients experienced a cesarean delivery last time. They might have had an epidural and tell you that they were in pain. They might have had a spinal and tell you they were in pain either during or after. So don't give them the same thing they had last time, crossing your fingers, hoping this time will go better. Do something different and tell them you're doing it. Tell them, thank you for letting me know. We're going to do something a little bit different this time. So you can give clonidine. These are the doses that are recommended, 30 to 60 microgram. The latest kid on the block is dexmedetomidine. I've started to use it 2 years ago when there was a shortage of clonidine in my hospital and it was driving me nuts. I decided I'm going to start using it very cautiously. I'll talk about both in a moment, but I can tell you that nowadays I prefer dexmedetomidine to clonidine. So at least 3 medication and possibly a 4th. Don't give both clonidine and dexmedetomidine, they do the same thing. So what if it's an intrapartum cesarean delivery? You have an epidural, be sure that it's working before you start dosing it with large volumes, because if you need to repeat the procedure and you've extended the epidural space or something that's close to the epidural space, you might have a high spinal. So make sure, check the back. Is it well taped? Is it working? Was it providing bilateral analgesia for labor? And start dosing with either lidocaine, or if it's really urgent, we use chloroprocaine. Add the opioid if the patient hasn't had it as part of a top-up in the last 2 hours. Give the morphine once you know baby's out. And you can also add clonidine or dexmedetomidine, and these are the epidural doses. So SOAP came up with a consensus statement, which is called the ERAC consensus statement. There are preoperative elements, intraoperative elements, and postoperative elements. I'm just going to focus on spinal hypotension prevention because it is essential and it is today standard of care to prevent hypotension, particularly if you're going to add a higher dose of bupivacaine or one of the alpha-2 agonists. You have to start with a prophylactic infusion of phenylephrine. This is what we use in the United States. In other countries, it might be another vasopressor if phenylephrine is not available, to maintain the blood pressure within 10% of baseline. Now, obviously, if the patient is preeclamptic and shows up in the operating room with a very high blood pressure, don't aim for 10% of that blood pressure, but you need to aim at something that is either within 10% in a healthy patient or with a MAP that is above 60, 70, depending on what your target is. If the blood pressure isn't maintained with your vasopressor infusion and you want to give a bolus, you can give phenylephrine, you can give ephedrine, and remember to do your co-loading. In the consensus statement, it still said preloading, but we know that co-loading is better during the spinal or the combined spinal epidural. So just a reminder, what are the spinal hypotension causes? It is a decrease in the sympathetic tone in the arterial system. It's not a reduction in the CVP, so it is important to really treat it at the core, which is with a vasoactive agent. That's why we don't tell you to preload patients. It has no purpose. And if your patient is a preeclamptic patient with magnesium or has peripartum cardiomyopathy and you didn't know it yet, you might precipitate patients into pulmonary edema. So it is really important to treat the sympathetic block with a vasoactive agent that will bring back the SVR. So as I mentioned, the different definitions, but the target is really to maintain within 10% of baseline, and you have surrogates for your cardiac output, since we're usually not measuring it, which is the heart rate. If you see that the blood pressure is starting to drop and the heart rate is going up, it is clearly due to a decrease in the SVR, and it is important to treat it. So we mentioned already, can we prevent? We can prevent. Can we treat? We can. Can we predict? There are many studies that have attempted to do prediction models, and I decided not to present any of the studies because I don't think it's prime time yet for something that is clinically relevant at the bedside. And it is remarkable because these studies have started 20 years ago, and whether it is heart rate variability, whether it is POCUS to see the fluid in the heart, the chambers of the heart, and see how filled the chambers are, it hasn't been shown to be a tool that you can use to predict hypotension. And usually we don't have much time to do these things outside of a research setting. So 3 things: fluid co-loading, tilt, which has been a little bit controversial. I don't know how many of you tilt patients. Show of hands. Who tilts? Who tilts until the surgeon starts and then stops the tilt? Okay. So tilting has been considered annoying for the surgeons, for the patients. We don't particularly like having the patient starting to roll over. But the reality is, right immediately after the spinal goes in, you start the phenylephrine. There's no harm and a lot of benefit to tilt patient. Approximately 10% of patients, if not more, do have supine hypotension, and tilting them will prevent the supine hypotension, sort of increasing the likelihood of a profound, severe hypotensive event. And you can use the 5 to 10 minutes until the surgeons are ready to start to have the patient tilted, and then you untilt when they're ready to start, which is actually what I do. Now I'm very curious, what are you guys seeing outside? Oh, square. Okay. Cute. Vasopressors, I already mentioned. Obviously, you have to start your vasopressors. So this is prevention and management. You have to have your vasopressors ready and ready to go. I used to spend a lot of time on these slides. I decided not to. There is so much literature, a lot of systematic reviews and network meta-analyses. And actually, it's interesting because we used to see so many papers presented at SOAP and other meetings about which vasopressor, which dose, how to initiate, how to maintain. And actually, if you look, there's not that many presented at meetings or published in the last 4 or 5 years. I don't want to say that it's not important. It's super important. But I think we've just sort of calibrated to know that in the US, we will all be using phenylephrine. In France, they all chose to use norepinephrine. In Brazil, people use metaraminol because it's available. And actually, if you look at the studies for the mother, metaraminol might actually be the best vasopressor. We don't have it in the US. Norepinephrine and phenylephrine are probably equal in the response, the hypotension management. And it doesn't matter whether it is an urgent C-section or a scheduled C-section, the response is really going to be titrated. Use what you're the most used to using. If it is norepinephrine, just be extremely cautious not to have extravasation and use a diluted formulation of your norepinephrine. I do worry that if we all switch to norepinephrine, we would end up having issues. And a lot of the editorials that were written accompanying all these papers were, why are we trying to fix a problem that we do not have? Phenylephrine works great. And yes, sometimes there is reflex bradycardia, but it's not really an issue that we worry about. And usually if there is reflex bradycardia, it's because you can reduce your phenylephrine dose. For the neonate or the fetus, there's also not that much difference between the three agents. What we do know is that ephedrine is not the agent to be used. I don't think anyone uses ephedrine to prevent hypotension. I don't think anyone uses only ephedrine reactively to treat hypotension. I do think that some of us will use ephedrine if the patient is not responding to phenylephrine the way we were hoping for, and usually it's after the baby is out anyway, and I think this is fine. So the bottom line, metaraminol, norepinephrine, phenylephrine, probably all the same, and not worth switching. None of them is significantly superior that you need to leave this lecture, go back to your institution and change whatever it is that you're using if it is one of these three agents. I did want to put out there a slide showing that, and people have asked me, what did I think about ondansetron and now dexamethasone in preventing hypotension? So it is interesting because you would think, why is it? So it is impacting and preventing the basal-gyrus reflex that might occur when you're laying down a patient after your spinal has gone in. So these studies are pretty recent. One of them is from 2020 in ANA. There are many more, but I put those that were published in journals that we know. So preoperative IV ondansetron will reduce the phenylephrine infusion ED50, so it has an effect on hypotension. And since we want to prevent nausea and vomiting anyway, why don't you start giving your ondansetron before the spinal rather than after, like many people do? So maybe this is something to think about. This is another study published in the Journal of Clinical Anesthesia that showed the same thing, but this time not with phenylephrine, but lower ephedrine dose in a study that was conducted, I think, in Turkey. And then a third study that was recently published in IJOA, where preoperative IV dexamethasone at 8 milligram really significantly reduced the incidence of spinal hypotension. We were very surprised to see dexamethasone given before, I see the squirrel, before the spinal, because we all know that it has this effect that patients will report if you have ever given it, of rectal perineal burning that is very noticeable. I think we once gave it unintentionally before the spinal went in. The patient was screaming. I have otherwise never witnessed that because I don't usually give it before the spinal. So in this study, what the authors did, it was all scheduled cases, so they had the luxury of being able to give it slowly, 30 minutes before, but they gave it over 10 to 15 minutes, and we specifically asked them to, tell us whether there were any incidences of this phenomenon of perineal burning, and they said there wasn't. So maybe something to take into account. I haven't started to give it before, but you can think about it if you're interested in the topic. So now we're going to talk about inadequate neuraxial anesthesia, the failed anesthetic. There are two definitions to it. One is our definition as the provider, the inability to achieve the desired sensory level. If you test the level, you're like, ooh, it's too low, or it's patchy, or it's one-sided. So for that, you need to obviously be testing the block. The other definition, which I urge you to think about as the one that really matters, although both matter, is the patient telling you, I am in pain. And we have discarded that for so long that for those of you who practice in the US, and I think it's a majority of us in the room today, you might have heard the podcast, did you see the coverage in the New York Times? I'm going to talk about it. But patients report pain during cesarean delivery in a frequency that is unexpected. So this is what matters, not that you say, oh, but the block is working. I had a T4 level 2 cold. She cannot be in pain. It's not pain, it's pressure. In other words, these two definitions need to be reconciled into one, which is you have to believe the patient no matter what it is that you checked and what it is that you found. So many studies in the past have looked at the interventions that we made in response to either finding that the block didn't work or to patients telling us that they were in pain. But usually studies have reported the need to repeat a planned neuraxial anesthetic, the need to give epidural supplementation, unplanned administration of IV adjuvants, or conversion to general anesthesia for pain. That's still not the patient-reported outcome. That's the stuff the anesthesiologist did in response to either testing a block that's inefficient or to the patient saying they're in pain. So I put here two columns, the patient-reported outcome, the stuff we do. So the patient-reported outcome is extremely dependent on what the expectations were. How many of your patients tell you, I want to feel nothing, that's what I'm expecting, that's what I want? Well, if that's what they think is going to happen, they're going to be extremely unsatisfied. There is no neuraxial anesthetic that is going to make them feel nothing. There are now many studies that, and we know that from being in the operating room, there are 3 sensations that patients will continue to feel, which should be tolerable. One is touch, one is pressure, and the third one is movement. They feel the movement, okay? So when a patient tells you, I'm feeling touch, you should reassure them. It is okay to feel touch because you are going to feel touch. But you need to also tell them that sensations that are going to be uncomfortable for them, no matter what they are, including pressure. Stop asking them, is it pressure or is it pain? And when the patient tells you it's pressure, you say, oh, that's normal. Because for some people, pressure is not bearable. And we see now many patients tell us, I felt extreme pressure, and I was told it was normal. There's 2 types of suffering in that situation. The lack of validation of a sensation that is uncomfortable, and the lack of response to that sensation. If the patient tells you, I'm feeling pressure, the next question should be, do you want something to make that pressure less uncomfortable? This is my recommendation. It hasn't made it into any guideline yet because it's the touchy-feely part of what we do, and it's very difficult to achieve, although when you think about it, it's very simple questions. Are you comfortable? Yes, no. What is making you be uncomfortable? Let them tell you what it is, and it doesn't matter what it is. But then the third question is, do you want me to give you something for that sensation that is uncomfortable? And you have to tell them before the surgery starts that there are things that we can do to make them more comfortable. Now, why am I insisting on the fact that you need to ask the patient if they want to be treated? Is because we've done many studies where we showed that we're not good at identifying pain and who actually wanted medication. So these are just the studies from the last 2 to 3 years and some review articles that were written. But there are 2 studies. One is one that we conducted, another one was conducted in Israel, where patients were asked if they experienced pain. And it was cross-referenced with whether patients received medication. And there are patients who didn't experience pain that got analgesic medication, and there are patients who did experience pain who did not get medication. And in the study that was conducted in Israel, they specifically asked the obstetrician and the anesthesiologist in the PACU, the patient you just took care of, did she have pain? And they asked patients in the PACU, did you have pain? And boy, did this not correlate. So we're not good at, and we make assumptions, and we've made assumptions for decades. Ooh, she's frowning. Ooh, she's making sounds that make me think she's in pain. Let me give her something. And for some patients, making sounds does not equate to being in pain. And for some patients, not making sounds and not frowning doesn't mean that they were not in pain. So we have to ask them. But we don't ask them if they're in pain, because asking about pain has a nocebo effect. Asking someone if they are in pain is increasing the likelihood they will start thinking about it, or that their pain score will be higher than if you ask them about comfort. Not just in the setting of cesarean delivery, but in all settings. We've seen that again and again in different types of studies. So change the way we communicate with patients. From the PACU, or for the holding area, into the operating room. As we're testing the block, we need to ask patients, we need to tell patients, we're going to ask you if you're comfortable. If you are not comfortable, let us know. And if you want us to give you medication, we have different options. This is what I do. I tell them I have medication for shivering, because one of the medications we give for shivering actually also treats pain and also has some anxiolytic effect, and that's dexmedetomidine. So I tell them there's medication that is going to help you with pain, help you with shivering, help you with some anxiety you may have. If they are really like telling you this is really painful, then we give them an analgesic, a pure analgesic. It can be fentanyl or another opioid. We usually give fentanyl. And we tell them, if that wasn't enough, we can give you more. Now, obviously, if there is an epidural in place, you can also use the epidural. And tell them, acknowledge, you heard them, you're doing something, you're giving them medication. And I tell them, I gave you something in the epidural, I'm giving you something in the IV, and ask them after a few minutes, are you feeling better? And if they say no, you tell them, I'm going to give you more. And if you feel that this is not going to help, you're going to tell them, I feel like we need to put you to sleep. And you will be surprised to see that some women, not quite a few, will tell you, I'm okay, I actually don't want to go to sleep. Or they will tell you, I don't want to go to sleep, but they're not okay. So this is the decision for you to make to put them to sleep. So show of hands, who've listened to the podcast of the Egg Retrieval Season 2? So you know what I'm talking about. If you haven't listened to it, you might want to listen to it. It's talking about one patient in Chicago who experienced pain and the moral and physical suffering of that situation. But it's not the only case. There have been many cases. This is just the most recent one, and probably the most dramatic one that is described now, this year, in the United States. So the incidence of patient-reported pain, so this is not the stuff we do. This is a study systematic review that was just recently published in a cohort of 11,000 patients, systematic review of 11,000 patients. Pain was reported in 14% of patients with a spinal, 18% of patients with a CSC, and 33% of patients with an epidural top-up. So a risk factor for experiencing pain, for sure the epidural. For sure the epidural that didn't work, for sure the epidural that's not dosed enough, for sure the epidural that's not redosed if the surgery is going longer, right? Because pain could have been at the beginning if it's an emergency, can be in the middle when your local anesthetics have worn off and you haven't redosed. So think about all these moments. If it's urgent or stat, give chloroprocaine. If it is stat, you give chloroprocaine. It's not going to last long enough for the C-section. Redose. But it's very important to bear in mind with an epidural, you're more likely to have pain during cesarean delivery. Should you pull the epidural and do a spinal? Big topic. I don't have the time to go over it. I would not do that if you know the epidural is working, because there is the risk of having the two compartments, even if your epidural medication has been just local anesthetics for labor, that you will have a spinal that might go higher than you wanted. And people don't want to be poked twice. So if your epidural is working great, don't pull the catheter. So there are two American Society of Anesthesia statements. The ASA released two statements, and there's an editorial. That's why you have a third QR code in IJOA about the steps. Pre-op assessment, reduce the risk of inadequate neuraxial anesthesia with all the things I mentioned, active management, replace the catheter, block testing, supplementation if it's insufficient neuraxial, conversion to GA, document, follow up, and have a quality improvement to assess every patient who experienced pain and see why it happened. And this is from a review article. Set the expectations, check the anesthesia, acknowledge any report of distress, make your surgeon stop. If it's not urgent, tell them to stop until your intervention has had the time to kick in. A lot of women will say, I said I was in pain, they continued. And often those sections are not that urgent. Oh, baby's already out and patient's not bleeding. Make them wait 2-3 minutes. Reassure the patient that you're listening to them, that you're acknowledging what they're experiencing, that you're giving them medication, that you can give more medication. And if nothing helps, offer the general anesthetic or tell them, I feel like at this point we need to put you to sleep. This is a not avoidable general anesthetic. Do it. And then you need to follow up with the patient because a lot of them will feel that something went very wrong. They didn't want that C-section to begin with, and then they ended up being put to sleep, put under, as they say. The birth, the delivery might have been stolen. And even if they were awake for the delivery, if you waited and put them to sleep after, they might not remember. Or they might feel, I didn't even see my baby, and then I was put to sleep. And the family member that was in the room is escorted out. It's very traumatic for the family. And ASA came up with a third statement on providing psychological support for obstetric patients. And the items that are brought in here, it's persistent pain, anxiety, postpartum depression, childbirth-related post-traumatic stress disorder. You need to follow up on the patients, and you need to provide trauma-informed care for patients who experienced trauma on their previous delivery, whether it was a vaginal or a cesarean delivery. And we need to provide empowerment to patients so that they don't come back even more traumatized from this delivery. So I talked about shivering, very important. Clonidine works, dexmedetomidine works. I'm sorry, it's not 405 micrograms. I just realized there's a typo. 4 to 5 micrograms. I had it on the previous slide. Epidural 10 micrograms, IV 10 micrograms. In our practice, we give IV dexmedetomidine almost to every patient, whether it is an intrapartum section, a scheduled section, and they're going to have a spinal. We started to give it even before the spinal goes in. We tell the patients we're giving them something. Who doesn't want to have something that's going to help them feel a little bit more relaxed? There is no downside, and it makes a big difference. Being intrigued by the use of intrathecal dexmedetomidine, we just published a scoping review. For those who don't know what a scoping review is, it's looking at everything that was published, no matter what journal, on whatever it is that you're interested. So doing a very robust literature search, we actually found 48 studies on the use of intrathecal, not IV, intrathecal dexmedetomidine for cesarean delivery. We were expecting 5, 6, 7 studies. We found 48. None of them was a good study. They were all terrible studies. I'll tell you in what way. Outcomes not well measured. The solution of the spinal was usually not what we would do typically for our patients. In other words, I cannot tell you what the dose is that we should be using when you do give fentanyl and morphine, which is what we do. None of the studies added dex to bupivacaine, fentanyl, and a morphine solution. It was usually instead. And the reason it was instead is that in most of the countries where these studies were conducted, opioids are not given in the spinal, and they're trying to enhance the bupivacaine that they're using alone. So the studies used between a very wide range. Some studies used up to 25 mics of intrathecal dexmedetomidine, but I would say the reasonable range should not be 10 when you're giving it in addition to the opioids. I would say it's 4 to 5 micrograms. So enhanced recovery, I already showed this slide. I wanted to raise your attention to the fact that while SOAP published guidelines in 2020, in the last few months, you might have seen in the American Journal of OBGYN 3 papers from the ERAS Society guidelines. Some of the authors from the SOAP guidelines contributed to the ERAS guidelines, and they produced a new set of guidelines that are quite similar to the SOAP guidelines, but they brought up a few new things. First of all, this time it's multidisciplinary because the SOAP guidelines were only, consensus statements, were only anesthesiologists. In this one, the obstetricians were included. And they included also patient representative in the consensus process, so much broader people, stakeholders around the table. Very strong recommendation for the antiemetic, strong recommendation for early feeding and reduced IV fluid duration, so this is post-op, which is different from the previous one. More specific recommendation about transfusion if patients are anemic and symptomatic. There was not really any guidelines in the 2021. And detailed guidelines on how to implement your ERAC protocol, which was missing and is one of the biggest challenges and hurdles in implementation of ERAC guidelines. So if you're interested in the topic, I urge you to look at the 2025 guidelines. And there's a checklist which I try to summarize. Fasting time, I mentioned it. It is there. I'm not telling you not to apply them, but remember, sometimes the downside of applying these rules is that you'll end up with a stat section where you don't have the time to do your spinal. Pre-op, give the oral acetaminophen. It's part of the checklist. Intra-op, before delivery, give the antiemetics, antibiotics. Keep your patients warm. Shivering management. Remember your spinal dose. Maybe use an alpha-2 agonist. Start your phenylephrine infusion. Analgesic supplementation if needed. And intra-operatively after delivery, uterotonics. I'm not covering it in this presentation, but there's a plethora of things, first line, second line, and the latest kid on the block is IV calcium that has uterotonic effects. Think about it if you feel that your patient has a contraindication to methogen or prostaglandins. Calcium is an alternative. And think about your IV ketorolac, your NSAIDs, and analgesic supplementation. Opioid-sparing multimodal, you have to use and apply stepwise multimodal analgesia. Pre-op and intraoperatively, I already mentioned, post-operatively, and for rescue as needed, your opioids and lidocaine patches. For managing complications, for itching, use IV nalbuphine. For neuraxyl opioid-induced hypothermia, I don't know how many of you are aware of it. This occurs in 10% of patients who get neuraxyl morphine. Your patient gets extremely hypothermic with subjective warmth. They might be even sweating. They're extremely nauseous. They might be itching. People are not aware of this phenomenon. It happens in 10% of patients. If you start looking for it in your PACU, you will see it. It is reversible with IV nalbuphine since it is induced by the opioid. And a tailored approach to pain management for your patients who've told you they've had pain last time or chronic opioid use or complex surgery. It is okay to enhance the spinal dose of everything, of the morphine, of the clonidine, of the dexmedetomidine. If you have an epidural in place, keep your epidural catheter. You can keep it for 48 hours. You can use a neuraxyl labor analgesia infusion. You can decide you're not doing that because patients won't be able to get out of bed. You can redose morphine, 3 milligrams every 12 to 24 hours. You need to have a mechanism to monitor patients, but if that's needed, and that is what is going to make patients comfortable, be able to ambulate and not become systemic opioid dependent with a persistent opioid use. Do that. You can consider gabapentin, ketamine, or dexmedetomidine infusion if it's available, and abdominal wall blocks may provide some pain relief as well. So this is my last slide. Priorities and future directions. We need to avoid general anesthesia whenever possible. Remember the rapid sequence spinal. If you're doing a general anesthetic, do a modified RSA, prevent awareness, ensure postoperative pain. Active management of neuraxyl labor analgesia, I cannot emphasize how important it is. Don't keep in place an epidural that's not working for labor. You never know when the patient is going to go to the operating room. Check analgesia, replace the neuraxyl, use adjuvants. Prevent pain during cesarean delivery, test the block, communicate with the patient, manage intraoperative pain, debrief with the patient, with the obstetrician, with your nurses who didn't tell you that it was an epidural, that it wasn't working, with the family, with the providers. Optimize neuraxyl anesthesia. We talked about all the elements. And I hope that with that we can reduce healthcare disparities and provide the best care possible to every woman around the world who's having a cesarean delivery and contribute to their well-being and not to childbirth-related PTSD. Thank you very much. As part of refresher courses, I'm told I'm not expected to take questions, but if you have a burning question, I'm happy to take one.
Yeah, can you elaborate just tiny more on the dexmedetomidine? What percentage of your patients gets a spinal dexmedetomidine? Do you give dexmedetomidine in epidural space for a top-offs? And if you can just say a few words, all my patients says I'm a big baby and I hate needles. Do you give 4 mics of dexmedetomidine IV when they come to the, or you give 10, you give 4 plus 4 or something?
Okay. To the babies and the not babies, I give 10 IV, okay? I also give spinal dex. So what percentage? If it's me, everyone. If it's not me, not everyone, but more and more. My colleagues are starting to love it as much as I do. And top-up, you asked me about the top-up. I have less used dex epidurally, but I'm starting to use it as well. So are you asking for labor or in the operating room through the epidural? Labor? I rarely. We're still using clonidine, but we might switch to dex. I do want to emphasize one thing important. Thank you for asking this question. You need to use preservative-free dexmedetomidine. Not all formulations are essential. The reason we don't use it for labor epidural is that we don't have it preservative-free in our epidural carts. Not a good reason, but just a practical one. In the operating room, we do. That's why we don't currently. So very important. Look at the vial, and if it's not written on the vial, look at the package insert of that specific vial. So the 200 mics in 2 ml in the US, most of them are. The bags of 4 mics per ml are not. The IV bags, the ones that are used in the ICU or in the operating room or in peds, are not. And some vials of 4 mics per ml are. So it's tricky. Please, yes, look first.
Great. Thank you for the lecture, John Markley from New Jersey. So one other thing he asked was, do you reduce the dose of the bupivacaine when you add your dexmedetomidine? I had seen some editorials and things where they dose reduce the heavy bupi. And second, and when you induce general, using straight propofol or propofol ketamine, is there an impact on baby?
To your first question, I feel, do I dare say that I don't reduce the dose and I actually often increase the dose? I've increased my doses. I am so worried of patients feeling pain that I often give 1.8 with 4 mics of dexmedetomidine. Now, I failed to say one thing. Why did I switch to dex from clonidine? There's less hypotension. So it is as efficient in terms of shivering, if not more. It is as efficient in reducing this visceral tugging, pulling, movement sensation that patients report so often. And it induces less hypotension, which was the biggest issue. So it's not an issue in the operating room because you have your phenylephrine infusion, but it might be an issue to wean them off, to stop the phenylephrine infusion if your surgeons are really quick and they're still on the max effect of bupivacaine and the dex or clonidine. So for hypotensive purposes, that's why I've switched to dex. Your question about how do I induce general anesthesia? I often don't induce general anesthesia, but on the rare cases where I used to do propofol ketamine. I like this combination of, 1 milligram per kilo of propofol and 1 milligram per kilo of ketamine. I've stopped using ketamine altogether when we started using dexmedetomidine. I think ketamine does have this effect that we all dread of, patients will tell you I was in the matrix. And some of the benefits of it, which were postpartum depression, other things, I don't think that there's sufficient evidence to show that there's a benefit. and it is a controlled substance. So, drawing up the ketamine and all this is more cumbersome than the Precedex. We really use Precedex. So an induction for general anesthesia, probably, propofol, and I would maintain them on propofol and Precedex during the C-section. Thank you very much.